Good afternoon. I'd like to thank the organizers for inviting me to give this talk today on the association between diabetes, obesity, and COVID-19. It's not unprecedented that diabetes has some association with an infectious disease, and there is an increased risk of infections in people living with diabetes. And if we look at another two current day pandemics, namely TB and HIV infection, there's also a strong association with diabetes. I have no disclosures that are pertinent to this talk today. And just a quick outline of the talk. I'm first going to review the prevalence of diabetes and obesity globally and in Africa. We'll then explore whether there are plausible pathophysiologic mechanisms explaining why patients with diabetes or obesity would be at greater risk of infection or complications from SARS-CoV-2 infection. We'll then look at some global data on the association between diabetes, obesity, and COVID-19. And then we'll have a look at some local Western Cape data on the association of diabetes and COVID-19. This slide just goes to remind all healthcare workers that there are now over 450 million people living with diabetes globally. And if we focus down on Africa in the bottom left-hand corner, you can see that over the next 10 to 20 years, Africa is going to experience the greatest increase in prevalence of diabetes, increasing by about 143%. If we then take a snapshot of the Africa region, you can see that South Africa is the leader with the greatest number of people living with diabetes, but there are at least already 5 countries in Africa that have over 1 million people living with diabetes. This is also on the backdrop of an increasing prevalence of overweight and obesity in Africa over the last 2 decades. And this is greater in women than in men. And so there's no doubt that it was destined that these 3 pandemics were going to meet. And so the question now is, are there plausible pathophysiologic mechanisms explaining why patients with diabetes or obesity would be at greater risk of infection or complications from SARS-CoV-2 infection? This slide is now very well known to everyone, and it describes the entry point of SARS-CoV-2 into cells using the ACE2 receptor. Once the ACE2 receptor is downregulated, you can see that the flux of the whole pathway is driven down the angiotensin II pathway, ultimately leading to hypertension, cardiac fibrosis, thrombosis, and ARDS, all things we know that are part of complicated COVID-19 infection. And in people living with diabetes, ACE2 receptors are increased, especially when they are hyperglycemic. There is a background of endothelial dysfunction in people living with diabetes and obesity, and it's now become quite well described that in the setting of COVID-19, there's an endotheliitis. And all 3 of these things, these entities, putting pressure on the endothelium and increasing release of pro-inflammatory cytokines, all aid the formation of the cytokine storm that ultimately leads to multi-organ failure. And if you have a look at the description of the organs involved in multi-organ failure, you can see that these are quite typical of quite severe COVID-19. So if we have a look at a summary then of why diabetes may put you at risk, the entry of the SARS-CoV-2 into the respiratory tract is like in anyone else. You get infection of the respiratory epithelium and ultimately the development of a pneumonia. There is increased ACE2 expression in people living with diabetes, and especially on the cardiac myocytes and in the kidney. And then it's also very well described in people living with diabetes that there is a dysregulated immune system, all putting one at risk of developing a cytokine storm and multi-organ failure. And not to forget that this is generally in patients with type 2 diabetes who are usually of an increased age, they're usually overweight or obese, and they have some degree of pre-existing vascular disease or pre-existing kidney disease, all of these which have been associated with more severe COVID-19. A very interesting question that hasn't been fully answered yet is whether actually SARS-CoV-2 infection can cause diabetes. We know that in the SARS pandemic, there were cases of new diabetes, and it was shown that the spike protein was toxic to beta cells. We know now from the literature that there's frequent reports of new onset diabetic ketoacidosis, and there's also frequent reports of people requiring large doses of insulin in order to maintain euglycemia. It's very important to remember that obesity is a state of low-grade chronic inflammation with areas of hypoxia amongst the adipocytes, which drive a pro-inflammatory environment, especially with TNF-alpha, interferon gamma, and interleukin-6, and especially the interleukin-6, which has been associated with a cytokine storm. And so it's this milieu of chronic low-grade inflammation that may place overweight and obese people at risk of developing more severe COVID-19 when infected with SARS-CoV-2. We also know that obesity is associated with some degree of respiratory dysfunction. There's often associated comorbidities, and they also have metabolic risk factors, which together would likely all culminate in more severe course of COVID-19. An interesting theory that has been put through is that SARS-CoV-2 gains entry via the respiratory system. There's extra pulmonary organ spread, and we know that there's a predominance of ACE2 receptors on adipocytes, and the SARS-CoV-2 virus gains access to these adipocytes, and then these adipocytes act as a reservoir for viral shedding, thus prolonging and aggravating the course of COVID-19. And this is just a summary of everything that I've said in the setting of obesity, showing how chronic inflammation, a dysregulated immune response, dysfunctional metabolism, an imbalance in epithelium, and dysfunctional immune cells all could potentially put someone who is overweight or obese at risk of developing more severe COVID-19. And so now that we've had a look at the possibility that there are actually pathophysiologic mechanisms explaining why people living with diabetes or obesity could develop more severe COVID-19, the next question then is, actually do they? And to initially outline this, I'm going to use global data. And the first question we need to ask ourselves is, do people living with diabetes have a greater risk of being infected with SARS-CoV-2? Now, this is a very difficult question to answer because the information that we need is the number of people with diabetes that have been diagnosed with COVID-19. And then we need to know everyone that has had COVID-19. Now, we know that many people have asymptomatic infection. And to know the denominator is impossible at the moment because many people have escaped diagnosis because they've been asymptomatic. And then all the articles in the published literature are generally on the more severe COVID-19 with those that have been hospitalized. But the data that is available from other countries basically shows that there is no increased prevalence of diabetes in all patients diagnosed with COVID-19, suggesting then that people living with diabetes or obesity are not at greater risk of getting infected with SARS-CoV-2. However, the next question is, once they are diagnosed with COVID-19, do people living with diabetes or obesity have more severe disease when they have been diagnosed? And I'm going to use the initial studies from 3 or 4 of the countries in the Northern Hemisphere that have been hardest hit by this pandemic to illustrate the point. There are now multiple studies in the literature essentially showing this at the moment. So if we have a look at the first study from the United States on 5,700 patients admitted to hospital, at least 1/3 had pre-existing diabetes, and people living with diabetes were more likely to require admission to the intensive care unit. In a large study from Italy on about 1,600 patients admitted to the ICU, 1 in 6, 1 in 7 of these patients had pre-existing diabetes. And in a large study from China, if you have a look at the overall case fatality rate, it was 2.3%. But if you focus then on people living with diabetes, it was 3-fold higher. In a large study from the United Kingdom, looking at 17 million adults that had accessed the national health system in the year prior to being diagnosed with COVID-19, and you can see that obesity and increasing obesity and diabetes were both associated with a greater mortality from COVID-19. There are now multiple studies and systematic reviews and meta-analyses and cohort series. I've just used 3 here to illustrate the point, but essentially all of them show that obesity increases your risk of more severe COVID-19 disease. It increases your risk of requirement for admission. It increases your risk for admission to an intensive care unit. And unfortunately, it also increases mortality from COVID-19. But also just to say, before we change the slide, that all these studies are observational studies. So although there's now a plethora of data and meta-analyses and systematic reviews, all the data is essentially mainly showing an association between diabetes, obesity, and more severe COVID-19. We can't, at this stage, imply causality. So then let's look at some data from the Western Cape that for many months was the epicenter of COVID-19 in Africa and in South Africa. This was data that as of the beginning of July 2020, and at this stage in the Western Cape, there were about 72,808 people that had been diagnosed with COVID-19. And of those, about 7,000 had pre-existing diabetes. And so this put the prevalence of diabetics in this population at 9.6%. And if we have a look at the background prevalence of diabetes in our population, which is widely quoted to be somewhere between 10 to 12%, you can see that there actually isn't a greater prevalence of people living with diabetes in the COVID-19 population, suggesting then that people living with diabetes are not at greater risk of becoming infected with SARS-CoV-2. However, if we have a look at these diabetics, almost 50% of them required admission to a hospital, showing that they were more likely to have more severe COVID-19. And of those of which we have an outcome, which was about 2,201 patients, there was a very high mortality of almost 43%. Again, now showing that diabetes spells a more severe course of COVID-19 with greater morbidity and greater mortality. A recently published comorbidity report from the Western Cape, having a look at the association with COVID-19 death in all Western Cape public sector patients who were over 20 years of age and who had accessed the public healthcare system in the prior 3 years. So this was a population of about 3.5 million people. It was quite well shown that diabetes by itself was a risk factor for death. You can see here diabetes with a well-controlled A1C was a risk factor. And this increased dramatically if you had poorly controlled diabetes, such that people living with diabetes who had an A1C greater than 9% had a hazard ratio for death from COVID-19 of 12. One of the interesting associations from some of the data from the Western Cape was showing that 80% of all people living with diabetes who were admitted to hospital were actually diagnosed with COVID-19 on the day of their admission or after their admission, essentially showing that these patients were presenting late with their symptoms and presenting when their symptoms were severe enough for them to require admission. I think therein lies the opportunity potentially to intervene if we can get people living with diabetes to present earlier. When their symptoms are milder, one could potentially put in place some type of monitoring, some type of telemedicine to help and to monitor these patients and to ensure early access to healthcare facilities to possibly decrease the morbidity and mortality associated with their course of COVID-19. There's very preliminary data at the moment, and it's quite sparse, to show that if one is able to control diabetes when the patient is admitted to hospital, one could change the outcome. This is a study from China where they had a look at the glucose variability in patients that were admitted. And what they found was that if patients were able to keep their glucose readings between 4 and 10, the outcome was much better than if they had excursions that were greater than 10 millimoles per liter. And you can see over here that those who had poorly controlled diabetes had a greater mortality than those who had better controlled diabetes. So in summary then, there was bound to be a meeting of the pandemics of diabetes, obesity, and COVID-19. There are plausible putative mechanisms suggesting why people living with diabetes or obesity would have greater morbidity and mortality from COVID-19. Data at the moment doesn't suggest that people living with diabetes or obesity are at greater risk of being infected with SARS-CoV-2. People living with diabetes or obesity are more likely to have more severe COVID-19 with a greater morbidity and mortality. And it seems that very early data shows that if one could control glycemia in the context of an admission and in hospital, one may be able to change the outcome in these patients. Thank you very much for listening, and I'm happy to answer any questions.